All right. So this talk, I will first tell you, cannot be done in 10 minutes. We're going to get at least a touch of things, and then we could really talk about this for an hour easily. But I'm really happy to talk about this today. I talk about this topic a lot. These are my disclosures. The one on here that is relevant is the Novo Nordisk speaker, and I will tell you that I do speak for them. I'm one of only 3 surgeons who speaks for them, and I think we actually need more surgeons who do that because I get access to a population of providers and different people that I would never have access to otherwise, and I get to talk about surgery as well. But it doesn't actually impact this talk significantly. I am going to talk about how bariatric surgery does work through the neurohormonal pathways. There's a variable response to surgery, and medications can be used to enhance the outcomes of surgery. So I think this is one of the critical takeaway points today, is that obesity is a disease of the brain. The brain is the master regulator for hunger, satiety, and metabolism. And this is actually done through connections between the gut and the brain. And this is a little more simplified diagram, but basically there are a lot of really important gut hormones that interact directly with the brain, affecting appetite and energy expenditure. This is another really key take-home point. Our surgery that we do, metabolic bariatric surgery, works through changing the biochemistry and the physiology. It is not about restriction and absorption. We actually permanently change biochemistry. And this is important to understand because medications cannot do this. This is just one of the articles that reviewed the mechanisms of specifically sleeve gastrectomy. And what you find is mechanistically, hormonally, it's actually very, very similar to a gastric bypass. GLP-1 is the hot topic of the day, but to understand what does this do, it improves blood sugar control, reduces extra production of sugar. Purposefully, one of the mechanisms is to delay gastric emptying. That's not a complication, it's a part of the expected effect. And it directly reduces appetite through direct CNS signals. What we understand is that different procedures impact these different pathways differently. And so sleeve really has a strong impact on ghrelin, a little less on GLP-1 versus a gastric bypass would have a little more GLP-1. But understanding those differences can help us. And these are things I'm just reinforcing that other speakers have said. There's a variable response to any treatment we have, and that includes bariatric surgery. So a lot of times we quote patients what's average. We have to understand some are super responders, some are partial responders, and that's expected. This is one of my favorite articles. There's actually several of these done in different populations, but this was in the Dutch population. And it's like a growth curve for our 2 biggest surgeries, the bypass and the sleeve. And what you find is that the bypass has higher weight loss at every point, but it's actually very, very close. And the shape of the curves is the same. And so despite what people think about sleeves having more weight regain, they actually don't. And the shape of the curves is the same. But what it also shows is that every patient will have a change in weight over nadir, and that's expected. So we have to decide, when is that pathologic? Well, why does this happen? It's probably a lot of different things, but what we find is maybe these partial responders don't have as strong of GLP-1 effect, and that can impact weight regain. And there's some other important articles by Dr. Carol LaRue that were mentioned earlier in the keynote as well, but very good work done on this. This is what Joe was talking about earlier. One of the biggest causes of weight regain after weight loss, whether it's medical weight loss, diet and exercise, or surgical weight loss, is hormone adaptation. So the body actually upregulates these other hormones and makes people more hungry, decreases their satiety. But if we can control that abnormal physiology, we can control the behavior. Physiology drives behavior. So we said the number 1 cause of weight gain is snacking. If we can control that desire to snack, we can actually control the behavior. So can we alter the patient's response to surgery? And I would suggest we can. And one of the ways we can is use of medications. We can use these to augment what surgery is doing. Surgery is our most powerful tool, make no mistake. But we can use medications pre-surgery, with surgery, post-surgery, very much in the way that we use medications to treat cancer in combination with surgery. This is just to give you an idea. These medications work directly through the brain, and many of them work through something called the brain's reward center, or John called it hedonistic center. It actually affects the reward people get from food and eating. And again, understanding the differences in the procedure can help us tailor our approach. There are actually, this is just big categories. Again, I can't get into the nitty-gritty details, but the GLP-1 receptor agonists are the big dog on the block. They're the Ferrari, right? So they're really powerful. The ones you'll know of is tirzepatide, semaglutide, liraglutide, and then there's the older ones like dulaglutide and exenatide. These decrease hunger and improve metabolism, but also have a direct CNS effect, and a lot of people don't realize that. Other medications can be useful that are very cheap these days. SGLT2 inhibitors, these are very popular in cardiology for heart failure. Metformin is a great base tool that's cheap and easily available. Phentermine can be very helpful, but especially when you combine it with other medications. It's a stimulant, but also works in that brain reward center. We have a medication called Contrave or bupropion with naltrexone. This helps decrease the pleasure signals. And so when they're talking about GLP-1s helping people with addictions, guess what? This is working through that same pathway. Topiramate can work great when it's combined with other medications, but we call this medication Stupamax because it slows brain and they feel like they have brain fog. So if you don't put it with phentermine, it can be very hard to tolerate. We have medications like Vyvanse and sertraline that can be very helpful. Prior binge eaters prior to, say, gastric bypass surgery tend to become snackers. They don't continue to binge eat in large portions, but they become snackers. So controlling that is important. Well, has this been done? The answer is yes. We actually have a fair amount of data. It's growing. People are using these medications in their practices all the time, but the data is growing in this area. So we have the utility of weight loss medications after bariatric surgery. This is one of the earliest studies that was published by Dr. Fatima Cody Stanford. This is bypass patients, okay? We talk a lot about sleeve gain, weight gain. This is bypasses. They'd gained weight after their bypass. They started topiramate and then added phentermine. And they found out not only could they get them back down to their nadir, they could get them lower than their nadir. And so by adding medications, they could get about 20 pounds. Now remember, Eric Wilson said, remember 10 kilos for endoscopic therapies. This is going to be in that same range. So Phentop, again, phentermine topiramate, this is one of the studies that actually really changed my practice from Jamie Ard. And this is in high BMI patients because there's a lot of discussion about, well, a sleeve's just not powerful enough for a patient with a BMI over 60. It doesn't matter if that's the right procedure for them because of safety, it just doesn't have the power. And so, but what we find is when you combine it with medications, it does have equal power. So this study used phentermine topiramate pre-surgery, brought them down and continued it for 2 years post-surgery, and they found that, look at that, 2/3 were able to get a BMI under 40. So when we had that discussion the other day about transplants and having to get them under 40, yes, you can do a sleeve and get a pre-transplant patient down under 40. Another article, more recent in SWORD with high BMI, again, greater than 60. This is sleeves and bypasses. And the group that had medications pre-op had 31% total body weight loss. And these are high BMI patients. And it's important when we talk about weight loss that we talk about total body weight loss, not excess body weight loss, because that's very impacted by their starting BMI. Now, if for the group that didn't start medicines pre-op, but only started it if they didn't have optimal weight loss, their total body weight loss was 25%. And for the group who just had surgery, their total body weight loss was 20.8%. So significant difference starting it ahead of time. Then we have this one that looked at liraglutide and semaglutide, which are both GLP-1s after bariatric surgery. And what they basically found is and this is only after 6 months of therapy, okay? We're not talking yet at a year or 2 years, which is even more. At 6 months, 8% of total body weight reduction, which is really very significant for most patients. So they got rid of 2/3 of their weight regain in only 6 months on medication. This is, again, the same semaglutide versus liraglutide, but they were comparing them. Basically, semaglutide had higher weight loss. It's a little more powerful. So if you have your choice, you'd pick the more powerful drug. But again, for those getting over 10% of excess weight loss, the odds ratios were 2.3, but 2.5 were over 15% of total body weight loss after the medications. This is a randomized placebo-controlled study in the Lancet, the Gravitas. And this is looking at liraglutide, but at the diabetes dose. Now, that's not the weight loss dose. That's the 1.8 milligram dose. And this was really to improve hemoglobin A1C. And what they saw is that they could improve the hemoglobin A1C regardless of which type of surgery the patient had prior. And their mean weight loss change after 26 weeks, which is not very far, about 6 months, was 4.2 kilos. And this is, again, not the weight loss dose, the diabetes dose. This shows liraglutide in the Bariatric randomized clinical trial. And this was if they had suboptimal initial GLP-1 response to surgery, and then they got the GLP-1, and they were defining essentially kind of weight loss failure in that 20% or less body weight loss. And what they find is liraglutide at the weight loss dose now at 3.0 milligrams for 6 months had a total body weight loss of 8.8, which is much higher than placebo. So this was the ASMBS review paper on anti-obesity medications. And what we found is that the weight loss with the medication seemed to be similar when used after surgery as it was in patients who've never had surgery, and that it was an additive effect. Even if we're using a GLP-1 receptor agonist, it works differently than the natural GLP-1 surge that we're getting, so they can actually be additive. And there's a higher cumulative weight loss for those who have an AOM if you start it at a plateau rather than if you wait until a weight recurrence to start it. So again, the data is still emerging. There's still a lot of art with this science. I've been prescribing medicines in combination with surgery for over 10 years, and we evolve and we change. So I get a lot of this. Holy smokes, how am I going to do that? You can learn to do this. Yes, I have a ABOM, obesity medicine certification, but more importantly, you can get people to help you. And my PAs and my NPs do the heavy lift here. So this is the take-home points. This is the money stuff. Obesity is a chronic progressive disease, and we are not curing it with surgery. We are treating it. It is best treated with multimodal therapy, very similar to cancer treatment. So we can use neoadjuvant therapy, we can use combination therapy with surgery, and we can use adjuvant therapy. We can use it to treat a recurrence of the disease. We don't use recidivism, by the way. We're going to talk about that more. It's disease recurrence or progression. And yes, you are a doctor and you can prescribe medicines. This is amazing. So understanding that this is a physiology problem, just like Eric said, that is the basis of everything that we do. And that helps us better understand how to attack this problem long term. So thank you for your time and attention. I'm going to have the panelists come back up and we'll take some questions.